Welcome everyone and good evening to the special webinar on COPD or chronic obstructive pulmonary disease for World COPD Day. I'm Letitia Harding, the Chief Executive of the Asthma and Respiratory Foundation New Zealand, and I'll be your host tonight. The theme of the discussion tonight is Know Your Lung Health, which is the theme of the 2024 World COPD Day, actually. And tonight you'll hear from two fantastic medical experts, who I will introduce in a moment, on the evolution of COPD care in New Zealand. And they're also here to answer your questions around COPD and also offer insights into things like how spirometry plays into working with people who have COPD, the latest treatments, the importance of pulmonary rehabilitation and exercise. So our first presenter tonight is Professor Bob Hancox, and he is the Foundation's Medical Director and also a respiratory physician. So welcome, Bob. And if you can just introduce yourself and also just say a few words about your role and what you do with COPD.
Thank you, Letitia. Well, yes, well, you've introduced me. So I'm Bob. I'm a respiratory physician based in a hospital, but also based at the University of Otago. So I have a mixed sort of research and seeing patient role. So what I do with COPD, well, as a hospital-based specialist, mostly I see people who come in to hospital with exacerbations or who get referred into the outpatient clinic. So I tend to see people at the more severe end of the spectrum. And so that's where most of my experience is. I'm also involved in writing the COPD guidelines. And research-wise, I'm interested in the early development of COPD using data from the Dunedin longitudinal study, which many people will have heard of. And I'm also interested in the overlap between COPD and other diseases, such as heart disease, because we realize that a lot of our patients with COPD often have other diseases as well, and we need to do what we can to help people with those other diseases, not just treat their COPD. So that's me.
That crossover. Thanks, Bob. And our second presenter is Dr. Sarah Candy, and Sarah is an advanced clinician of physiotherapy as well as a better breathing coordinator. So welcome, Sarah, and the same if you can just tell about your role and how it relates to COPD.
Thanks, Letitia. Kia ora koutou. My name is Sarah. I work at Middlemore Hospital here in Auckland. I'm a physiotherapist, part of the respiratory service, and I have been for several years now. I spend the majority of my time working in our pulmonary rehabilitation programs, and I'm very fortunate in that I get to spend a lot of time with people who are living with COPD, with them and their whānau. And because people tend to come to pulmonary rehab twice a week for 8 weeks, we get the opportunity to really get to know people well, get to be part of their lived experience of living with COPD. And in fact, one of my participants said to me just today how the best thing she did this year was come along to Better Breathing. And I questioned her a little bit more about why that was. And she said it was that by coming along each week, she could ask those questions as things come up, as she had challenges day to day, she could talk through those with us. So I think that's a really big difference that we can make for people by having that time and that opportunity to see them make some really important health improvements. So thank you for inviting me to be here this evening, and it's a pleasure to be part of World COPD Day.
Thanks, Sarah. So I'll just do a bit of housekeeping and explain a bit about how the webinar will work tonight. We want this to be an interactive opportunity, so you can ask questions of our presenters. We've also already got a whole load of questions which have come through, so thank you to those who've registered and sent those through. As I said, you're welcome to ask questions during the course of it because we can see it pop up in the chat to the side of us. Use your Q&A function down the bottom if you do want to ask a question. Just select that down the bottom of your screen. And I'll keep an eye on those questions as well as we go through. So I'll just look at what we've got around some of these first questions coming through to us. And I guess what we might do before we start with those is perhaps just, Bob, if I start with you, can you talk just a little bit as a background around the evolution of COPD in Aotearoa in particular, and perhaps like, you know, our guidelines and evolution, what's really stood out for you, maybe just a couple of minutes, those changes over the last sort of decade. I know that's quick to do in 2 or 3 minutes, but some of the things that have really stood out.
Well, I think COPD treatment has been an evolution rather than a revolution. There are some exciting new developments which haven't reached New Zealand yet, and I think we'll talk about those a little bit later. But we've got medications that we've had for several years now, but we are learning better how to use them better, and what combinations of inhalers work best for different people, and how to identify which people need what inhaler. And so the COPD guidelines, which we produced a few years ago, and we're just about to update them probably next year, were the first ever COPD guidelines for New Zealand, and to try and raise the level of COPD care. There's a few things that have been interesting over the last few years. One is what happened during COVID, in that when COVID happened and people locked down, as well as getting rid of COVID, we got rid of all the other respiratory viruses. And it was remarkable to see how well people with COPD were during that time, because we got rid of respiratory viruses. And that highlighted the importance of trying to stay well from all these nasty bugs that people have. And it's obviously very hard to stay away from viruses when you're not in lockdown. You know, the grandkids bring them home, you know, people going out to the supermarket and so on. But actually trying to keep well, getting vaccinations, particularly against flu, are just really, really important for people with COPD. And the other thing, and I'm going to put Sarah on the spot in a minute, is the real importance of people think of treatment as being the medications and the drugs, but actually the non-drug treatments are really, really important. And things like pulmonary rehabilitation, we just come to realize how really important those are. So things such as pulmonary rehab, getting exercise, and staying well through vaccinations, obviously quitting smoking, these are really key to improving COPD care.
Thanks, Bob. And I guess that's a nice chance to ask a question of Sarah, because it fits nicely. The audience, I'm sure, is really interested to find out what role rehabilitation does play and how that's changed over the last sort of decade, and the importance of that as a complement to the medical therapy, as Bob was saying, Sarah.
Yeah, look, pulmonary rehabilitation is really important in the management of COPD, and it's not actually all that new. Interestingly, it's 30 years today since the first randomized control trial was published on pulmonary rehab for people with COPD. And in the last 30 years, there's been a huge amount of research that has really consolidated the fact that pulmonary rehab works. It really does make an important difference for people living with COPD. For those that are able to get to a program, they will get some really meaningful improvements in their health. They'll feel less short of breath. They'll have better exercise tolerance. What that really means is that they'll be able to do the things that are important to them, whether that be mowing the lawns or doing their own grocery shopping. In addition, it shows that we can get improvements in quality of life. And also we know that people who attend pulmonary rehab are less likely to be hospitalised with exacerbation. So really important benefits from pulmonary rehab. We think of pulmonary rehab as exercise. Exercise is just one part of pulmonary rehab. It is actually a really important component of pulmonary rehab, but it's not all we do. But if there is one thing, if you can't access a formal pulmonary rehab program, then doing some exercise, become a little bit more active in your day-to-day activities is still a really positive step to managing COPD. What we know happens is that with COPDs, there's a real gradual decline in activity levels. So as things become difficult, whether it's mowing the lawns or walking a flight of stairs, people tend to start to avoid activities. That results in a little bit of deconditioning and muscle wasting. And then if you have an exacerbation and have some time in bed, that really makes things a lot worse. So exercise can improve and reverse some of the problems associated with that deconditioning, and it really can make quite a significant difference in the lives of people living with COPD.
Thanks, Sarah. And Bob, I'll start with you on this question that's come through as well. What role does spirometry have to play in COPD, whether that's, defining COPD, or do people have it done frequently throughout their COPD course of treatment, or?
Sure. With good question. I think it's fundamental. Spirometry is the way to diagnose COPD. By definition, all the accepted definitions of COPD are really based on measuring how good or how bad lung function is using spirometry. And so it's actually very difficult to diagnose COPD without spirometry. A little bit like trying to diagnose high blood pressure without actually measuring it. We really shouldn't be doing that. Sometimes we all come across patients who haven't had spirometry and we suspect they've got COPD because of their symptoms. And often we're right. When we do the spirometry, find we're right. But occasionally we find we're wrong. And the risk is we treat people with the wrong medications if we don't actually do the spirometry to work out what their lung function is. It's also very useful for judging how severe the COPD is. So there's a whole different ways of grading the severity of COPD, but most of them are based on spirometry. And so it is fundamental. Does it need to be done very often? No, it probably doesn't. It probably needs to be done occasionally, but it certainly needs to be done when you're diagnosed. We can use it sometimes to assess people's response to treatment. If we're going to try a new treatment, sometimes we can use spirometry before and after the treatment to see how effective that treatment is. But for most people, just getting it measured occasionally is enough, but it should be measured.
Thanks, Bob. And I guess with just sticking before we get to the next question, Sarah, around spirometry, is that something people have while they're having the rehabilitation? Is it something where they get it done frequently at different stages or whatever during that course of the rehabilitation?
So we would do spirometry as part of an assessment for pulmonary rehab, but we would only do it at the beginning of a program, and that's part of just ensuring that their treatment is optimised. We wouldn't do spirometry as an outcome measure, so we don't do it at the end of the program. We tend to just do it at the beginning. However, if someone's recently had spirometry, then we wouldn't repeat it again.
Okay. Thanks, Sarah. And we've had a question actually come through on the live webinar Q&A, which I'll ask you, Sarah. Someone's put in, how far should you push yourself during exercise? What oxygen level is unsafe during exercise? And I guess that's the question you often get is like, how hard do you push yourself and to really get the most out of that rehabilitation?
Yeah, it's a really good question, and you're absolutely right. This is the question that does come up quite a bit. We tend to go by something which is fairly easy to use, which we call the walk and talk test. So I recommend that people exercise at a level where they can just talk. So if when you're exercising, you're huffing and you can't get your words out, then you're going too fast. If you're whistling or you're singing, then you're not going fast enough and you may want to go a little bit harder. So the walk and talk is the easiest way of guiding intensity. With regard to oxygen levels, this depends a little bit. Not everyone with COPD will have reductions in their oxygen levels. It would depend if you have some oxygen at home. It would tend to be something that would be a good idea to have an exercise test done with a monitor to understand what your oxygen levels are like. But if you're using a little home pulse oximeter and your oxygen levels are tending to go below 88% while you're exercising, then that is probably something that I would highlight with your doctor.
Right. Thanks, Sarah. Bob, I've got one through here for you. When would you consider DLCO, so diffusing capacity of the lungs, and do you ever consider FOT, forced oscillation technique? Okay,
yes, well, good questions. So for many in the audience who wouldn't necessarily have heard of these, DLCO is gas transfer. It's a measurement of how good your lungs are obtaining oxygen from a breath. So I use it a lot, but I'm spoiled because I work in a hospital and I've got a laboratory that can do it quite easily. It's not as important as spirometry, but I think some people who have only mild abnormalities on spirometry, they might have a lot of emphysema, but not much airflow obstruction, not much airways disease, but a lot of emphysema. and that will show up on the DLCO quite well. So it's sort of useful additional information. It's very useful in people who haven't got COPD, who've got other forms of lung disease. And so often I will do it when somebody comes in for the first time and I'm trying to work out what's going on. I will do the DLCO. I wouldn't necessarily repeat it very often unless there's a good reason to. And it is useful in COPD. It's probably more useful for people with breathing disorders that are not COPD. So that's when I would do it. The forced oscillation technique. Now, it's a really interesting technique, which is actually measuring how sound waves travel through the lungs. So basically you breathe on a microphone and the microphone makes noises, and then it picks up the noises being reflected back from the lung. It's an extraordinarily clever technique. It's been around for quite a long time, but it's only really in recent years that we've had good enough computers to actually do this practically. And I've used it in research. I've never used it clinically. I just don't think we know enough about it and how it should alter what we do for it to be have prime time in the clinic. It is a useful technique. It does show abnormalities of people with lung disease, but what it adds to spirometry, I'm not sure yet. So I don't actually use it clinically. I have used it in research.
Right. Thanks, Bob. And this we've got a question that's come in the live webinar, but also that one that was sent through, which is sort of there be similar questions. Has New Zealand started to fund and manage COPD with monoclonal ABs? If not, why not? And is this info shared with patients who may wish to self-fund MABs? And if you can think about that question. And then the question that's come on the webinar is, I'm 76 years old, lifetime severe asthmatic, bronchiectasis, COPD, frequent pneumonia, good self-care, puffing, breathing exercises, good diet, sleep, environmental control of allergens, inhalers no longer work on prednisone, anything incoming treatment for those like me. So I guessed, are MABs something for COPD? Are they funded? Can patients self-fund?
No, yeah, that's not at the moment. So no, they haven't come in. They've only just started to be registered overseas. There is only one monoclonal antibody that has been shown to have any effect in COPD. It has now been funded, I think, in Europe and only just in the last month or so in the United States. It isn't registered as a medicine in New Zealand, so even if people wanted to pay for it, we can't actually get it in New Zealand because it's not registered. Knowing what the costs are, I think it would be tens of thousands, maybe $100,000 or more a year, looking at what the list price is in the United States. Who knows what it would cost you to get it from overseas? And I don't know if there are any cheap suppliers sort of making generics. I think probably not. So you'd probably have to buy it at full cost to get it from somewhere overseas, and it will cost you very large amounts of money. It has a modest effect. Would we like to have it in New Zealand? Yes, we would. Are we going to get it anytime soon? I suspect not, because I cannot see Pharmac funding it. And the company have not even registered, as far as I know, the company have not even registered it as a medication here. So it's not something that I could prescribe as a doctor, even if somebody was willing to self-fund it. It does seem to have some benefit. It's probably not a game changer, not a huge change, but it is always useful to get alternative medications. For your anonymous attendee who's 76, with inhalers no longer working on prednisone, well, I mean, it's very difficult to give individual advice here, but I think it would be really worth getting the inhalers and other treatments that reassessed and seeing whether there is a better combination of inhalers. We try to keep people off prednisone if we can, and I'm sure that the attendee is aware of that, but sometimes we just struggle to do that. Yeah, I don't think any time sooner there is going to be a new medication that's going to solve their problem.
Right. Thanks, Bob. And Sarah, this came through as well earlier. What role can family, or what role does family or whānau play in supporting someone on their COPD journey with rehabilitation? So how important are those support networks?
Look, I think family is hugely important. We really encourage participants, if they have family members that wish to come along to rehab with them, then I think that that is really important. I think that family, it's really hard to sometimes understand what the person with COPD is actually experiencing, and it's hard to know how to best help them. So along at a pulmonary rehab program, there's usually an education session, so a little interactive chat about a different topic each time, and I think that those sessions are really informative for family members to be involved in. Covering topics is range that from how do the medications work and how to take them correctly, what are the signs of an infection and what's the best course of action, around what sort of foods to be eating, how to pace yourself, how to stay active, all those kind of topics which can really help in the day-to-day managing. I think the best thing that family members can do is to support, encourage and assist people to stay as active as they possibly can. And if that means little and often walking around the house or outings, I think that is one of the most beneficial things that we can do to support people.
Thanks, Sarah. Just another quick question for you, Sarah. Will pets and pollen, like allergens, make my COPD symptoms worse? Should I not have a dog if I've got COPD, or a cat?
Goodness. There is potential if you have that phenotype, if you are allergic, that your pet may be a source of causing some exacerbation of your airways disease. I don't know, Bob, do you have anything to add there?
It depends if you're allergic to it, to the pet or the dog or the cat. That would be more common in people with asthma than COPD. COPD tends not to be an allergic type disease, although, and there are some questions coming through the chat, all the questions and answers are about this overlap between asthma and COPD, which is something we may need to talk about. So if you have a history of long-standing asthma, you know you're allergic to a cat or dog, then it would make a lot of sense to avoid them, because it may well make your airways worse. But that tends to be more asthma than COPD.
Right. And one of the questions from an attendee here, what are the earliest signs of COPD and how can someone differentiate them from common respiratory issues, Bob?
Well, probably it's fair to say that COPD is one of the most common respiratory issues. The other one that is most difficult to distinguish it from is asthma, because they have very, very similar symptoms. Those symptoms tend to be shortness of breath, coughing, particularly coughing up phlegm, but not all, sometimes a dry cough, difficulty exercising because of their short of breath, wheezing, and it tends to come and go. So you have good days and bad days. So people with asthma tend to have had it, not always, but tend to have developed it fairly early in life and have had symptoms from quite a young age. Whereas people with COPD only tend to develop it later in life, usually after some years of exposure to things like smoking particularly, but sometimes other may cause it. I think there's another question relating to this, is that actually sometimes it's very difficult to tell the difference between asthma and COPD. And so we talk about a thing called asthma COPD overlap syndrome. Now, international societies vary about whether they agree that there is such a thing as an overlap or not. I mean, we tend to think it's a useful term to talk about overlap, because there really are some people who may have had asthma for a long time, but they may have also smoked and they've got these symptoms, and we really can't work out what the major cause is. What the major cause is probably less relevant for that person than what we can do about it. And if we're not sure, and there's a history suggestive of asthma, we tend to treat for asthma, because the inhalers for asthma will often work for COPD, but it's really important that we don't miss out on the inhaled steroids for that person. So there are some people where it's very difficult to tell them apart. I see that, do you mind if I go on to one of the questions? Because I see that one of the your questions is about Nucala for severe asthma. And your question is quite right that Nucala is a monoclonal antibody for asthma, but it's only actually approved for asthma. It's not approved for COPD. And I don't think it's been shown to be very effective for COPD. So to get that, the person must have qualified to have that on the basis that somebody thinks that there's a component of asthma there, and particularly asthma associated with a particular form of eosinophilic air inflammation to qualify for that in New Zealand. So, but it can be very difficult. We know that people with really long-standing asthma can develop an identical picture to people with COPD, and so sometimes we just have difficulty telling them apart.
Right. Thanks, Bob. And Sarah, what we've got a question here. What role does, if any, nutrition play in COPD, or as part of rehabilitation? Is nutrition, diet, an important part of it?
Yeah, that's a great question. It's a really important part. Most pulmonary rehab programs would certainly include a nutritional component in the assessment, and would include some advice and information, hopefully from a dietitian, as part of the program as well. I guess we are often most worried about people living with COPD who are thin, who are underweight, because they often don't have the energy that they need, and that is exacerbated with an exercise program. So it can be difficult to get enough calories in, particularly if you are very short of breath, and you sometimes may need some nutritional support in the way of some supplements to help keep your weight up. And the other dietary recommendation is we tend to encourage people to eat smaller, more frequent meals rather than big meals. And this is just because eating a big meal can sometimes make it a little bit harder to breathe, just because your tummy and your lungs are so close together, that big meals can actually exacerbate some breathlessness. So better off to eat frequently and smaller meals. And for family members, particularly, if someone is quite unwell with their COPD and is really short of breath, then looking at really soft foods is particularly helpful. So staying away from foods that need a lot of chewing, because you can't chew and breathe very well at the same time. So soft foods, soups and stews and smoothies are particularly helpful when you have an exacerbation, or if you are at a stage where you are quite short of breath.
It's very helpful. Thanks, Sarah. This is quite I think this might be a sort of clinical question here that's come through, Bob. Z-scores versus FEV1% interpretation, which one and why, or do we combine them for a clearer picture? And maybe just for people who are on this, maybe explaining what Z-score and the FEV1% actually are would be good.
Yeah, well, again, an interesting and fraught issue. I use both. The short answer, because I've got both. The most respiratory scientists and laboratories around the world now are thinking that Z-scores are better, because they provide what the normal values are in terms of a standard deviation score, and I'll explain that in a minute. And so for different age groups, for different people, what we expect a normal person to be able to blow out varies. And so the old practice of using percent predicted is a little bit difficult to interpret, or at least it can get the diagnosis wrong. You either underdiagnose or overdiagnosis just by looking at the percent predicted. So the Z score is better, but it is very difficult to understand what a Z score is unless you've done quite complicated mathematics. And so I tend to use both because it's much easier for me to say to somebody, your FEV1 is only 60% of what it should be. And that's using the percent predicted. And people can understand that. And if I say it's 80% or 40%, that makes sense. If I say your 1.5 Z scores below normal, that means very little to people. So in terms of judging whether the lung function is normal or not, I tend to look at the Z score. In terms of explaining it to people, I tend to use the percent predicted. But I'm in the luxurious position that my laboratory provides me with both. And so that's maybe sitting on the fence a wee bit there, but that's how I do it.
Thanks, Bob. And this next question is probably for both of you, and maybe start with Sarah first. What role, does or the importance of good mental health play? This is a long-term chronic condition. Do you often find, people can suffer with depression, or you've really got to look after that mental health with this as well?
Yeah, absolutely. We know that unfortunately the rates of anxiety and depression are really high with any chronic illness, and particularly with chronic obstructive pulmonary disease, and understandably so, because you often, people living with COPD can't do the things that they enjoy or that they want to do because they're limited by breathlessness, and that can often mean they may become socially isolated and at home a lot more and on their own, and that can have a big impact on the mental health. I think when someone is suffering with anxiety or depression, it just makes it harder to be able to manage their health condition. So I think that it's really important that we are identifying and helping to support people, or getting the right supports in place to manage that.
And I guess being aware of it as a component of this, and making sure that people have the opportunity to talk about it, I guess, as well, Sarah. Bob, do you have anything to add with that side?
No, I think Sarah's covered it, really. We do emphasize in the guidelines the importance of looking at other health issues, and I've talked a little bit about cardiac problems that sometimes people with COPD also get. But mental health issues are the other really, really, really important one that we need to take care of. And so, and there's all sorts of reasons why chronic illnesses such as COPD do cause poor mental health, or increase the risk for poor mental health. So it's very important we take care of those as well.
While I've got you, Bob, this is a question, of course, we know the answer to this, but some probably don't. Do you have to have been a smoker to get COPD?
You don't have to. We find that in New Zealand, probably most people are smokers who get COPD. That would be the big risk factor, by far and away the most important risk factor in New Zealand. As I alluded to before, there are people with asthma who've had it since childhood who end up with airways that look very much like COPD if we measure them on a spirometry. But we believe that what's actually happening in the airways, the pathology, if you like, is not the same. But there are other exposures that could cause COPD. So if you're spending a lot of time being exposed to other forms of smoke, you could get COPD. We used to worry a lot about people working in smoky environments. So people maybe worked in restaurants or bars when there was a lot of smoking indoors. So they may not smoke themselves, but they'd be inhaling lots of other people's smoke. And of course, if you've lived all your life with a heavy smoker, and particularly grown up with a heavy smoker, that increases your risk. Having said all that, it's far, far more common in people who smoke themselves.
Right. Thanks, Bob. Yes, it reminds me of those times when you used to be on the airplanes where you could smoke in a tiny closed environment, and there was smoking on airplanes. So not so good for people who were air stewardess back in the 70s. Terrible. And I've got another question here. that we've got come through. Bob, why do we give patients incentive spirometers post-surgery even though they're oxygenating well?
Actually, I think that's probably better for Sarah than me, because I think that's a very physio
Sarah.
question.
Sure, happy
Sorry,
to
Sarah.
answer that question. So an incentive spirometer is a tool, an adjunct that physiotherapists sometimes use to assist patients with breathing exercises. It's a little tool that you breathe into that gives a little bit of feedback as to how well you're doing with your breath in. It is often, well, it's routinely used in the hospital if somebody has rib fractures or a spinal cord injury. And it's often used after surgery if someone has lots of pain and is having difficulty taking a deep breath. So even though their oxygen levels might be perfect, they might be at risk of a little bit of atelectasis or lung collapse just from pain and positioning and bed rest. And the incentive spirometer is just to increase the lung volumes really and help give people a little bit of support and feedback into taking some deep breaths.
Thanks, Sarah. And actually, there's some questions which have come through specifically for you, Sarah, which is good. Just asking, I guess I can wrap these into one sort of question, asking how do people find out about what programs are where around the country, and how do they access those? Do they have to go to their healthcare professional, their primary care provider, like a GP first, to get like a referral? Where is that central, I guess, information for people?
Yeah, great question. So just about every main hospital across New Zealand does offer a pulmonary rehabilitation program. The last time we looked into this, there was just under 40 programs across the country. With regard to referral to those programs, it depends a little bit on the individual service. So some services will allow self-referrals, meaning patients can contact the program themselves. Some services require people to have come through the GP or even a respiratory consultant. So it does depend a little bit on the service itself. I think a really good starting point, or two things. Firstly is the Asthma and Respiratory Foundation website does have a list of all the pulmonary rehabilitation programs across the country with a contact number and email address, so you can seek some more information from your local service that way. But definitely recommend talking to your GP and asking your GP about a referral to a pulmonary rehab program.
Thanks, Sarah. And we'll get a link out to people with the exact link. Our website has a lot of information on it over a lot of areas. So we'll get the specific link for people to be able to find out where they can find that list of services as well. I think will be really important. We've also got another question that's come through here. Bob, you may want to take this one. Is there a link between FEV1 and life expectancy?
Yes, there is. In fact, there's a link between when you do spirometry, you get two basic measures. One was FEV1, which is how much air you can breathe out in 1 second. And the other one is FVC, which is how much air you can breathe out in total. And both of them are linked to life expectancy. And we're not entirely sure why, but people with impaired lung function do tend to have a shorter life expectancy. It's not an absolute determinant, of course. It's just one of many risk factors, and we're still trying to really work out why that is. But yes, there's a link which has been shown in study after study, and it's not necessarily that people with poor FEV1s live shorter lives because of their lung disease. It may well be other aspects of health, but there is a link.
Thanks, Bob. And just also to let people know, as I know we're sort of starting to wind down a bit here, that we will be sending out more COPD resources and a video recording for all of those with a link to this recording for those who have attended, and you can also then share that link as well. And we'll type into the questions here just that if you've got any feedback or anything specific you would like to ask around this, you can email marketing@arfnz.org.nz and we'll collect all of those questions and bits and pieces there. So I guess just in a wrap up, and we'll start with Bob, since you're on the screen. If you were going to give a sort of final word for people who are living with COPD, they've been diagnosed, you know, what are the sort of top 3 tips or things to look out for if you're going to, you know, wrap it up in ending this session?
Okay, with regard to pharmaceuticals, drug treatments, make sure you're on the right inhalers. We haven't talked about it yet much, but we now have more inhalers coming online containing similar drugs, and if you're on several inhalers, that's becoming increasingly unnecessary, because we have at least one now funded with the 3 different medications all in one inhaler, and we have another one coming online next year. So make sure you're on the inhalers which suit you and have got the right medications in that. And that's something you need to talk to your health professional about. And because a lot of people don't get the full benefit out of their inhaler because they don't understand how it works, or they've got an inhaler that doesn't suit them. Don't forget the importance of the non-pharmaceutical measures. It's you know, getting exercise, go to pulmonary rehab if you can, get your vaccinations. All of these are really important, and obviously don't smoke. You know, if you are smoking, please quit, and persuade your kids and your family not to smoke as well.
That's important. Thanks, Bob. And Sarah, if you were sort of like the top 3 things you'd like to leave our audience with in regards to, you know, living well with COPD?
Yeah, look, number 1 is very easy for me. Just keep active, stay moving, find a way for exercise to be your friend. The benefits of exercise are just so potent, but sadly they only stay with us as long as we keep exercising. So the best thing you can do is to stay active. It doesn't need to be complicated, it doesn't need to be expensive. It's just find an activity that you enjoy. Better still, have a friend or a family member that participates with you. But staying active is by far my number 1. And then I think just those pillars of health to stay well. So good food, good sleep, and staying active are so important. And my 3rd one is listening to your body, being aware of those symptoms, those signs and symptoms. So knowing the signs for you of when things are changing, knowing if you're more short of breath, if your phlegm changes colour, but the sooner you seek some help when you have those symptoms of an exacerbation, the better, really, because we don't want to wait and see what will happen and that end up in a hospitalisation.
Yeah. Fantastic. Thanks, Bob, and thanks, Sarah, for a really informative webinar. And thanks to so many people who sent in their questions beforehand and also asked online. That concludes our World COPD Day webinar. As I said, get in touch, send us an email if you have any questions, or go to the website as well, because we have a lot of resources on the Asthma and Respiratory Foundation website, and we can type that into the answer box, but probably many of you know where the website is anyway. So just kia pai tō pō, and thank you so much.